Dr. Roxana Moran. She has too many titles, but I'll go through a few of them. So she's the Mount Sinai Professor in Cardiovascular Clinical Research and Outcomes. She is a Professor of Medicine and Population Health Science and Policy at the Icahn School of Medicine at Mount Sinai. And I know she doesn't need any real introductions, but as we all know, she's an internationally renowned interventional cardiologist and researcher in the field of cardiovascular disease. She has built a globally respected academic research center focused on developing randomized clinical trials and has served as a principal investigator, as you know, for many studies, developed risk scores for bleeding and acute kidney injury, and participates regularly in clinical guideline development. She has authored more than 1,000 peer-reviewed articles and has been included as one of the most cited researchers in the world. She is currently a member of the ACC Board of Trustees and is a founder and chief scientific officer of the Cardiovascular Research Foundation and founded Women as One, dedicated to advancing opportunities for women in medicine. Dr. Moran has received many awards, including the 2016 ACC Bernadine Healy Leadership in CV Disease Award, the 2018 Annette Wenger Award from Women's Heart for Excellence in Research and Education, the 2019 Ellis Island Medal of Honor, and the 2019 ESC Silver Medal, and the Andreas Grunzig Lecture Plaque. So without further ado, I want to introduce Dr. Moran, and thank you so much for joining us today as our Locke visiting professor. Finally, I want to thank the Locke family and foundation for sponsoring this visiting professorship.
Thank you, Dr. Yang, my colleagues and dear friends, and thank you for having me. I had a wonderful day yesterday with the Interventional Cardiology Group, but it's really an honor to be with all of you today to give you a little bit of a snapshot of the most complicated arena for us clinicians who take care of, and for all of you clinicians who take care of patients after a coronary intervention regarding the antiplatelet therapy. And I'll take you, it's important for you to note my disclosures. They're also been sent, and I'm sure they'll be published for you to look at. Importantly, I led the one that I will be speaking about, the TWILIGHT study that I was a principal investigator of, which was funded by AstraZeneca, but sponsored by the Icahn School of Medicine, as well as the Science short DAPT programs. So some of you might recall the father of angioplasty, Andreas Grunzig, and he actually thought about the idea of antiplatelet therapy as he believed that the injury in the vessel with the balloon catheter would be a thrombus-inducing situation. And he was correct in that he felt very strongly that platelets play a role in angioplasty. Now we know, especially in stenting, and that this would be the, nonetheless has become the cornerstone, especially dual antiplatelet therapies in after PCI. And it's really about the platelet-mediated thrombosis targets, and especially on the activation aggregation side, where we are working really, really hard. And the compounds that we're going to talk about a lot is clopidogrel, prasugrel, ticagrelor, and then of course this guy, aspirin, that we're very, very closely associated with. And it really is that most of the drugs that we use are in this pathway of activation. But let me take you a little bit through the timelines and how it all started in 1998. Where it was when stents were getting used, what was going on is we were giving Coumadin and patients were bleeding, and it was a nightmare. And it was this fantastic trial that showed the use of a P2Y12 inhibitor at that time, taclopidine, versus the conventional anticoagulation was associated with better results, less stent thrombosis, and an ability to be able to control some of that bleeding. But of course, taclopidine did have an important issue, especially on the bone marrow. And clopidogrel came to effect with the classic study led by Michel Bertrand, a double-blind study of clopidogrel with or without a loading dose in combination with aspirin, comparing that with ticlopidine, showing really great efficacy. But also very important study that I think everyone should note, because this 12 months of dual antiplatelet therapies that have been prescribed to stenting is really not about the stents. It's about the acute coronary syndrome patient presenting with an ACS and the cure data and the cure PCI data showing the benefit of aspirin plus clopidogrel compared to aspirin alone. The addition of clopidogrel in reducing cardiovascular death, MI, urgent revascularization, but not just to 30 days, but also beyond up to a year. And it was a 12-month reduction of these important events that led to the 12-month prescription of dual antiplatelet therapies to patients with an acute coronary syndrome. And I want to remind you that there is not an arm where we withdraw aspirin. It's always about withdrawing clopidogrel or adding clopidogrel to an established already evaluation of aspirin. Then we moved on to a potent P2Y12 inhibitor, the prasugrel, in the TIMI 38 study, the Triton TIMI 38 study led by Steve Wiviot, a huge study, over 13,000 patients, use of this irreversible, potent, extremely potent P2Y12 inhibitor, showing a reduction in patients who presented with an acute coronary syndromes, who went to the cath lab and had an anatomic, you knew their anatomy and they were undergoing PCI, a major reduction in cardiovascular death, MI, stroke, a major reduction in stent thrombosis, but a price to pay with some major bleeding, even some fatal events in certain patient populations, which was then later realized in subsequent sub-studies that then took out the prior stroke patient, the low weight patient, and of course the very elderly, frail patients not receiving this drug because of the association of undue bleeding that didn't really match the reduction in the cardiovascular ischemic events. And then we had ticagrelor, a different potent agent. This one is not a thienopyridine. It is an irreversible P2Y12 inhibitor that works without a prodrug. It's not a prodrug. It kind of comes along. And of course, a very important 18,000 patient study in acute coronary syndromes with or without STEMI, where there was a reduction in cardiovascular death, MI, stroke, and overall bleeding not being any different, but don't be fooled. There is no question that you will increase bleeding with ticagrelor compared to clopidogrel, especially non-CABG related bleeds. But what was very important here is that this wasn't just in PCI patients, it was all ACS, including STEMI. And at the time of presentation, so medically managed patients were also in this with a benefit. And importantly, there was a reduction in mortality in this trial. And then later on in 2013, we got to see an intravenous P2Y12 inhibitor, a very quick onset offset effect on the P2Y12 receptor with this agent cangrelor through the Champion Phoenix studies that included large numbers of patients, and looking at that acute event in the first 48 hours, both in the procedure as well as up to 48 hours, procedurally related events of death, MI, in ischemia-driven revascularization or intraprocedural stent thrombosis and 48-hour stent thrombosis significantly reduced with the use of cangrelor compared to clopidogrel upfront in a PCI patients. Here, there was no difference in the safety endpoint of severe bleeding, but there is some bleeding. But what's nice about this agent is that you could turn it off, and it's something for us to think about for in patients who have high thrombus load, who are coming to the cath lab, who haven't had the loading or any kind of a P2Y12 inhibitor on board, and you have complex anatomy with lots of thrombus. I think this agent could really, really be helpful. So the evidence is there where you're starting to see that dual antiplatelet therapy after stent implantation is important. And I put this up here because I want you to pay attention to the STARS study, because I think this comes back to tell us a lot here, where aspirin alone was really not doing well at all in terms of 30-day stent thrombosis rates and or death MI revascularization here, but certainly an important issue of 3.6%, coming down to 0.6% when you added teclopidine, but Coumadin plus aspirin also quite high. And we need to kind of remember one thing about all of these studies, the common theme of us never being able to let go of aspirin, always in the background, lurking about, and maybe not having a great anti-ischemic benefit at all, but perhaps working really well in bleeding. But let's go back to where we were. Once we left the bare metal stents to the drug-eluting stents, this disruptive technology allowed us to have much, much less restenosis and revascularizations. And there was this 3 to 6 month period of DAPT for these patients. And then we used it pretty much exclusively in every patient undergoing PCI. And then in 2006, we were met with a very, very difficult time of showing high levels of increased mortality compared to bare metal stents with both of these first generation devices, and understanding that this firestorm led to a reduction of the use of drug-eluting stents across the board from 90% down to 65%. And really an evaluation by the FDA to go to 12 months of dual antiplatelet therapies if you were going to use DES. And these were a lot of it due to the fact that there were these late safety signals with this first generation drug-eluting stent, and we went to 12 months. But the device manufacturers, scientists, researchers worked very, very fast to improve and enhance to the next generation or second generation DES with a durable polymer that was much more likely to be safer, especially with the everolimus-eluting stent, the Zion stent with the fluoropassivation that really shows retention of albumin and less platelet aggregation in the preclinical world, as well as the zodolimus-eluting stents showing less of an inflammatory response to that durable polymer. And in fact, in the very, very important analyses of the newer generation drug-eluting stents compared even to bare metal stents, certainly much better than first generation, better than bare metal stents in reducing stent thrombosis even out to 2 years. But then we began worrying about bleeding and what was going on with this 12 months of DAPT across the board for everybody, even in view of reducing and improving and enhancing those outcomes of stent thrombosis. We never let go of the long duration of DAPT. And we began to see that their bleeding matters. And here's data, the very first, I think, evaluation from the OASIS studies from John Eichelboom and Salim Youssef and Shamir Mehta, really telling us an alarm that bleeding is bad. Life-threatening major bleeds are associated with mortality. And we mustn't forget about bleeding in pursuit of protecting patients against these rare events of stent thrombosis or myocardial infarction. And at the very least, we should be looking at it. And of course, I spent the last decade really evaluating the impact of MI and bleeding, and really understanding that in a very detailed analyses working with Stuart Pocock, that actually both of these events are important, but bleeding is something that's durably important, not just in the first day or two or first 30 days, but actually across the board. We've got to be thinking about bleeding avoidance strategies. And as you can see, the impact of MI starts to kind of dissipate over time. and beyond 30 days becoming less and less important, as opposed to having a major bleed, which continues to have a very important association to mortality. And so this prolonged mortality risk is very, very important in terms of bleeding. And this was recapitulated by other investigators that showed that bleeding after DES matters even within 30 days or after 30 days, and really corroborating with what we were seeing here in prospective trials and validating that observation that we had seen. And so very quickly from that, as we improved our stent technology, we began thinking about, well, what is that optimal duration of DAPT when a patient presents with an acute coronary syndrome, or if a patient has stable coronary disease? Do we really have to go to a full 12 months on everyone? And so these different durations of studies came about with less than 12 months, greater than 12 months. And there's no question, shortening the duration of DAPT, guess what you will do? You will reduce bleeding. But is it as an expense of increasing myocardial infarction? And improving and going to a longer duration, you will increase bleeding, but you will reduce those important ischemic events. How do you choose then? Where do you go? What's the minimum duration of DAPT after a percutaneous coronary intervention with stents? And I think the multiple meta-analyses, and this one specifically, we were involved on several ones, have shown no advantage of really prolonging DAPT beyond 6 months in reducing thrombotic events, especially in those patients who are at high bleeding risk. And so we really, and with the current contemporary drug-eluting stents who have such a low event rates in terms of stent thrombosis or stent-related myocardial infarction. But this isn't to say that we need to go short on everyone. It's difficult because the DAPT study came out, and in patients who had tolerated a whole full year of dual antiplatelet therapy, they wanted to see, is there a benefit to extend that beyond a year? And of course, in those who passed the stress test for an entire year taking dual antiplatelet therapies, there was no question that you could evaluate that ethionopyridine continuing with aspirin is going to reduce those ischemic events. But guess what happened here? What was taken off was the ethionopyridine, not aspirin. And keep paying attention to this, of how we are so scared of withdrawing aspirin because we're just so dependent on this old therapy that has been cheap and around from the times of the early STEMI studies. Well, lo and behold, they did show exactly that. When you prolong DAPT in those patients who were doing fine, they kept having less stent thrombosis, less death, MI, and stroke. Significantly less. Those primary endpoints were met, but there was a price to be paid. The price was that of moderate to severe bleeding. It was tremendously higher. And by the way, mortality was in the wrong direction in this trial. So if MI and stent thrombosis and all those great events, ischemic events, were reduced, why was mortality in the wrong direction? And you can't tell me that this is just about, oh, underpowered, when you're seeing it coupled with increasing bleeding. And all of that data that I just showed you, that when you increase bleeding, you increase mortality, you begin to say, well, we better choose more judiciously on who we prolong dual antiplatelet therapies to. And so what we basically are saying, that an individualized based approach on ischemic and bleeding risk becomes the need of the hour. It's really important for us to think about that. And so on goes on the roller coaster of dual antiplatelet therapies. We started with 4 weeks. We went up to 12 months, as the highest 30 months. And we're back to the future of actually coming down as little as 1 month, especially in those patients who are at high bleeding risk. And so this yin and the yang of ischemic and bleeding events is something that torments all of us on a daily basis. Because, by the way, our patients who are bruising, and are really having a difficult time, those patients on an oral anticoagulant, where we know that they could have an increased risk of intracranial hemorrhage, how do you protect them against ischemic events if you peel away these great drugs? Well, it's important to also note that the one-year bleeding rates in DAPT trials are all over the place. And so it was important for us to come up with a really, really good definition. And very, very important to understand the role of aspirin in a contemporary world. There are real uncertainties now about the use of aspirin. We talk about the bleeding risk, especially the added bleeding risk when it's combined with a P2Y12 inhibitor, in increasing both extracranial and intracranial hemorrhages. But when you combine it, there is no question that aspirin has direct gastrotoxicity to the gastric mucosa, and we do have increased GI bleeds. It's also important to note that we've come a long way from the 3-4 decades past when we had no other drugs to treat the patient's risk factors. And the risk reduction with the current contemporary drugs have altered that patient's baseline risk, the individual risk for cardiovascular events, that translates to that relative benefits of aspirin becoming smaller and smaller as we go along. And then we have these amazing novel antithrombotics, the P2Y12 inhibitors, the novel oral anticoagulants and thrombin inhibition, especially in the COMPASS trial where we saw a really, really good evaluation. And the question is, when you have a potent antithrombotic therapy around, is aspirin use necessary? For how long? Can we shorten to that duration? And can we go understanding that the alternative dual therapy of P2Y12 inhibition is one that could have a very important impact on reducing ischemic events? And the rationale to go to a P2Y12 monotherapy comes to the fact that aspirin can actually abolish the excellent P2Y12 receptor blocker antithrombotic effect in vivo. And this is mediated by amplification of the inhibitory prostaglandins that are there. And it's a really important thing to think about what aspirin does here. And in fact, it has been shown that in the presence of a potent agent, prasugrel or ticagrelor, the role of aspirin in platelet function studies is really minimal in reducing platelet inhibition. And in fact, we saw that our Japanese colleagues took on the 1-month DAPT followed by clopidogrel monotherapy compared to 12 months of DAPT with the Zion Stent, which is that fluoropolymer, durable polymer, next generation everolimus-eluting stent. A lot of imaging. The Japanese colleagues do a lot of imaging, and they got a beautiful result showing that in combination of death, MI, stroke, and bleeding can be significantly reduced. Most of us all driven by reducing bleeding in these patients when you go to P2Y12 monotherapy after a month of DAPT and compared to 12 months of DAPT. And smart choice investigators showed exactly the same thing with 3 months of DAPT followed by P2Y12 monotherapy compared to 12 months of DAPT, showing no signal of harm in terms of death, MI, and stroke, but a reduction in bleeding, as you would expect. The global leaders investigators took this on in a much, much larger scale. They used aspirin and ticagrelor, a potent agent, in an all-comers PCI, 16,000 patients, in a pragmatic approach to say, if we use this experimental arm in everybody, aspirin and ticagrelor, stop the aspirin at 1 month, go to ticagrelor monotherapy for 23 months, we will actually reduce death and MI in patients compared to the current standard of care. Well, I would say that that was a lofty goal. The goal here should say that we actually want to reduce bleeding without increasing ischemic harm. And here you see that the all-cause mortality and Q-wave MI, which was the major endpoint was actually in favor of the experimental arm. And their lofty goal, unfortunately, was not achieved because they were not superior. But the fact is that there wasn't a signal of harm. And that gives me a very important hope that by reducing bleeding, that we could achieve and allow our patients who need those potent agents on board for a longer period of time. And that was the reason why, at the same time, we had designed the TWILIGHT trial. This is a double-blind, placebo-controlled trial looking at patients who would have a high-risk PCI discharged home on aspirin and ticagrelor, who did well for the first 3 months, were adherent to their drug, and did not have clinical events, who were then randomized at 3 months to ticagrelor plus aspirin versus ticagrelor plus placebo in a double-blind, placebo-controlled fashion, followed carefully for adherence. We made sure they stayed on their drug study, and we got 99.9% follow-up in these patients. And our primary endpoint was a superiority hypothesis in reducing bleeding, which was, of course, if this didn't happen, we were doing something really, really wrong in a double-blind, placebo-controlled fashion. And of course, we did do this with the numbers needed to treat of only 33 patients. But the much more important endpoint was, did we cause harm in withdrawing this most loved therapy, aspirin, in terms of death, MI, and stroke? Hard endpoints. And the answer to that is absolutely not. These curves were hugging each other throughout the post-randomization period with no difference at all, and a P non-inferiority being absolutely positive for absolutely no signal of harm when you do this. Our colleagues in Korea did this in an acute coronary syndrome setting, specifically, including STEMI. We did not include STEMI patients in TWILIGHT. 3 versus 12 months. They did the randomization at the time of PCI, and they showed the separation of the curves immediately after 3 months when they went to ticagrelor monotherapy in terms of reducing bleeding events. The net adverse clinical events were positive, but it was not because they reduced cardiac and cerebrovascular events. It was because, similar to TWILIGHT, they reduced bleeding. And they didn't show a signal of harm. So again, a second study that underlines the importance of this nice new therapy. But we can't go away from TWILIGHT and TICO without discussing this important trial, the ISAR REACT 5, which basically looked at ticagrelor versus prasugrel in patients with an acute coronary syndrome. A different randomization, for STEMI versus non-STEMI patients between the two arms. But they looked for a primary endpoint of death, MI, stroke at 1 year between these two potent agents, looking for superiority of ticagrelor, which was really kind of weird. Why would you want to see superiority in ticagrelor compared to prasugrel? But in acute coronary syndromes, and it was a funny randomization, but lo and behold, they actually showed the opposite of what they were looking for, where they found prasugrel to be very much in favor compared to ticagrelor in terms of reducing death, MI, stroke. But what was really odd in my mind is that you reduce that much death, MI, stroke, ischemic events without causing any important difference in BARC 3 to 5 bleeding, which was very, very, I think, significant for prasugrel. And perhaps many people now have switched from ticagrelor to prasugrel, and I say not so fast. These are very, very important to be repeated. Whenever you see a trial that is showing you something opposite of what you were thinking and opposite of the clinical biology, you need to repeat this. Do we now all of a sudden say that all these landmark studies in the past are no longer valid? Does the timing of the drug administration and the fact that the patients were actually only 80% received and stayed and adhered to the drugs they were assigned to, aren't those things important? So we need to repeat this before we say, oh, get away from ticagrelor. We also need to kind of think about this patient population. Everyone loves to talk about a high bleeding risk patient. Who are these patients? And every different trial uses different definitions. And so the Academic Research Consortium got together and came up with a well-validated, pragmatic approach of looking at these parameters that I've listed on the slide. If you get 2 minor and 1 major of these categories, you are then defined as a high bleeding risk patient. These clinical criteria are again listed here for you. And you can see that not all, and the reason why we did this is because, for example, not all elderly patients are created equal. Not all 80-year-olds are the same. I mean, we just saw Vice President Biden at the age of 78 running up to the podium, as opposed to other 78-year-olds that we see in nursing homes. So I don't think age is the only criteria, and we put that as a minor criteria, for example. Anemia, the same. So I think it's important to look at that and really evaluate who these patients are. There's an app for this. It's available in the App Store. Please get it and imagine how you could do this, because is it only about the bleeding? Yes, of course, you could reduce bleeding. These are validated high bleeding risk criteria, but it's also important as clinicians and the patients you send to the cath lab to make sure they get a really, really good evaluation at the time of PCI. And also to think about different scores that you could use, whether it's precise DAPT, Paris score that we developed, in evaluating the different durations of DAPT depending on the ischemic and bleeding risk, but also imagining what's the duration and what's the intensity of the treatment. So de-escalation, just as important as stopping the dual antiplatelet therapies. And then very, very important is the value of imaging. We know that intravascular ultrasound can be incredibly helpful. This is a very old study. Antonio Colombo, treating patients without any anticoagulation, once he was able to see that with proper sizing and proper stent apposition, he's able to reduce the ischemic events and stent thromboses. And the consensus documents on intracoronary imaging, especially in those high bleeding risk patients, are going to be very, very important. Unfortunately, not many people are using intravascular imaging. And there's so far no indication for high bleeding risk patients. But I can't imagine that you would send a high bleeding risk patient to the lab, that they would not be doing a meticulous job in only treating ischemia producing lesions using IFR or FFR, and making sure that if there is a bifurcation, multiple stents, that they're not making sure that you have a very, very good result. Because the meta-analysis of 19 studies with intravascular imaging versus not shows actually that IVUS guided versus angio-guided studies showing a reduction in stent thrombosis, myocardial infarction, and cardiovascular death. This should not be forgotten, and every high bleeding risk patient should have that. But unfortunately, the current snapshot and the situation in our cath labs are pretty bad. Only 51% of cardiologists use intravascular imaging in more than 15%. And I think this is an overestimation, because if you look at the NCDR, the numbers are in the single digits in different laboratories. But in high bleeding risk patients, I believe this is important, especially when you see the difference in reducing not just early MACE, but also late events out to 5 years. The durability of your result will be that much better documented when you use intravascular imaging. What trials do we have with the different high bleeding risk patients? And what are we doing? What about bare metal stents? Here's the first trial, 2,500 patients with high bleeding risk. These were patients that were never, ever studied before in stents. These patients were often excluded from our prospective randomized trials. In this double-blind randomized clinical trial, they used a biolumis-coated versus a bare metal stent-coated, a bare stent, the same bare stent versus the biolumis-coated in high bleeding risk patients with 1 month of DAPT, followed by a single antiplatelet therapy of aspirin, you got that right, looking at the primary safety endpoint. In 2,500 patients, of course, they showed a reduction in target lesion revascularization with a drug-coated stent. But look what happened with cardiac death, MI, and stent thrombosis. That was also lower than the bare metal stent. Bare metal stents should not be used in high bleeding risk patients. In fact, you should stop using them in your cath lab. The Onyx 1 investigators, and I was lucky to be on the executive committee of this, Stefan Windecker led this with the Zodolimus durable polymer Zodolimus eluting stent durable polymer, compared to this exact drug-coated stent that was just shown to be effective and much better than a bare stent in a first randomized high bleeding risk patient, showed non-inferiority compared to this. And now we have a 1 month FDA label for the Onyx stent for 1 month of dual antiplatelet therapies for high bleeding risk patients, because they showed, take a look at this, with the stent thrombosis rates still high at 1 year, 1.3%, but this is from time 0 all the way to 12 months. But very important reductions even in spontaneous myocardial infarction with the Resolute Onyx stent. These are secondary endpoints. The Evolve Short DAPT trial looked at the Synergy stent, a stent that was shown to be incredibly effective in the senior trial with 1 month or 3 months of DAPT with elderly patients. They showed a fantastic result compared to their historical control. And of course, they now hopefully will get, and if they already don't have, a 3 month duration of DAPT. And then most recently, I've just presented at TCT the Science short DAPT program, Science 90 and 28. This trial design were prospective single arm studies between 3 months and 1 month, and then a observation period of 3 to 12 months in Science 90, 1 to 6 months in Science 28 against the historical control of Science v. USA. These were all high bleeding risk patients. And what we showed in this propensity score stratified analysis, exactly the same event rates from 3 to 12 months in Science 90 on this single antiplatelet therapy compared to Science v. USA on dual antiplatelet therapy, showing and meeting that primary non-inferiority endpoint. And the same goes for Science 28, meeting that important endpoint. And I want to show you the stent thrombosis rates where we had a performance goal of 1.2% and only 0.2% or 4 patients had a stent thrombosis after 90 days to 12 months. And after 1 month to 6 months, only 0.3% of these patients in Science 28, sort of really underlying the very great safety endpoint of current generation DES. And of course, when you do this, you reduce bleeding, you reduce severe significant bleeds of 3 to 5, comparing 1 month to 12 months, 3 months to 12 months with this. And the current guidelines, irrespective of the intended dual antiplatelet duration, DES is the preferred treatment option for pretty much everyone. This is the ESC guidelines. And if we look at the Europe and the US guidelines on dual antiplatelet therapy, you can see that for all of the patients, the first question, whether they're stable or unstable, is the risk of bleeding that comes into here. And if they are high bleeding risk, you begin to get much shorter durations of DAPT, even in the ACS patient population. And I think this is really, really important. And now, with the advent of a P2Y12 monotherapy, you can even do better. So the evidence is still low, but I think it's a really, really good way for us to continue looking at this. Lastly, I want to talk to you about the highest risk patient who presents with an atrial fibrillation and needs a stent. Oral anticoagulants don't work very well against stent thrombosis. I showed that to you back in 1998 in the STARS trial. You need dual antiplatelet therapies early. And by the way, dual antiplatelet therapies are not sufficient for stroke prevention, an important endpoint for patients with atrial fibrillation. So if an AFib patient needs a stent, you're going to start combining these things, and you end up with what? A lot of bleeding, huge amounts of bleeding. What's important to note is that the novel oral anticoagulants and the oral anticoagulants, especially those, the factor 10A inhibitors, factor 2A inhibitors, do have some antiplatelet effect. So can you drop aspirin? And the WUST investigators did that. In 573 patients, prospective randomized trial, they just dropped aspirin at the time of PCI. And the patients went home with oral anticoagulant plus clopidogrel. And over that 1 year period, the bleeding was so significantly reduced that it was incredible. 64% reduction in all bleeding. But importantly, they didn't see a signal of harm. In fact, they saw a benefit almost in reducing ischemic events, which I would not pay a lot of attention to because we now have a lot of data from novel oral anticoagulants that say we don't have a signal of harm. And so the American perspective here now on these AFib patients is to have a default strategy of taking that aspirin off as soon as possible. And how do you do that? You evaluate the risk of bleeding versus the risk of ischemic events. If you're worried about multiple stents, bifurcation, et cetera, in an AFib patient, then you can give them up to a month of dual antiplatelet therapy in combination with an oral anticoagulant, but stop that aspirin as early as possible. If they have a high bleeding risk, well, you better have made sure that you did a great job with imaging and get that patient off aspirin very, very soon. I want to show you, in addition to Redual with Pradaxa, Pioneer with rivaroxaban, where there was a very, very important reduction in bleeding without ischemic harm. Everyone said, well, those were open label studies. As you know, Pioneer AF, less bleeding, reduced dose of rivaroxaban strategies, always reduced bleeding, no ischemic harm. In Redual PCI, same thing with the 2 different standard doses of dabigatran with that aspirin compared with VKA plus DAPT, all of them being open label. And everyone was saying, well, what about aspirin? Is it really safe to stop aspirin? And so this trial was undertaken, and it was a 2x2 factorial design looking at VKA versus apixaban, and then a secondary randomization to aspirin versus placebo in a double-blind placebo-controlled fashion. Really, really well conducted, largest trial. And immediately you see that apixaban plus placebo has the best effect in reducing bleeds. Next comes VKA plus placebo in bleeding reduction. Anytime you add aspirin, whether you're using a novel oral anticoagulant like apixaban or VKA, you have bleeding. But look at the VKA plus aspirin. That triple therapy arm is extremely dangerous for bleeding. Death and hospitalizations, best with apixaban plus placebo compared to VKA plus aspirin, with the numbers needed to treat of only 18. And in this meta-analysis of all of these AFib studies in PCI, what we're seeing is no signal of harm, the p-value 0.79 for MACE events, major reduction in bleeding. You can see that across the board, especially with a novel oral anticoagulant and a single antiplatelet regimen. But it's important to look at the independent and single endpoints. One of the things was, well, what about stroke? What doesn't look so bad? Myocardial infarction, death, overall MACE the same. But you see this stent thrombosis that makes us think about a little bit of a uneasiness that perhaps in certain patients, because the numbers needed to harm is really, really high, But you need to kind of think about this because we don't want to just move away and say, stop aspirin in everybody. But let me tell you what you will gain from stopping aspirin without a question is reduction of intracranial hemorrhage and all kinds of bleeds. So the take-home message on the update on dual antiplatelet therapies, it's all about the balance of ischemic and bleeding risk. And how you decide is up to you as the clinician who knows the patient best, understanding all these risk parameters and making an important choice for your patient, including that patient and educating that patient about both of these risks. This P2Y12 monotherapy, novel sort of way of thinking about this, dropping aspirin after a short course of DAPT, is an interesting strategy. Reduces bleeding without compromising ischemic protection, but it's not for everyone. You have to really look at the data and make sure that you're employing it in the kinds of patients who are in those trials. And then in AF patients undergoing PCI, there's no question in my mind that the sooner you drop the aspirin, the better off you are with your patient, making sure that all those patients have really excellent results at the time of PCI for the interventionalist to do a really good job. And then, of course, understanding that you will reduce bleeding without increasing ischemic events, but remembering that all of those trials were underpowered for those rare events like stent thrombosis. So you still comes back to you as the clinician to make that important decision about your patient. I want to thank you for your attention, and I think we do have some time for question and answers. Thank you again, Dr. Yang, for having me and all of my colleagues and friends at University of Washington.